meta-analysis involving patients who have all manifestation of coronary artery disease. And what is important is that there is a reduction of mortality, especially in the most sorry, there's a problem here. Okay. This reduction of mortality that is well known in the most complex patient, and indeed this has been welcomed and acknowledged by scientific societies, guidelines, and statement. There are limitations of transradial access, and they are mainly anatomical because of tortuosities and abnormal path. You have to develop knowledge on that and how to handle that. There is also a limitation in the size of the axis. Those are data in Japan where this problem is especially specific, but also there are techniques and tools to overcome those limitations. But probably the most important issue is radial artery occlusion. You see on the left, it's a meta-regression of study assessing the effect of radial artery occlusion, and you see there is a progressive reduction over time, but there is still a wide dispersion. Probably we are around, at the end of 2080, we are around 5%. We know it has been told many times from a clinical point of view, it's probably meaningless, but radial artery occlusion impedes to use the coronary the radial artery for future needs, such as coronary artery bypass graft or reconstructive surgery, maybe arteriovenous fistula for hemodialysis, but especially for repeated percutaneous vascular procedure. And you see on the middle panel that the success of further radial access drops with time. And this is especially important in the light of a new landscape of interventional practice, where there are interventional radiologists, neurointerventional specialists that are increasingly using the radial artery. So it's quite important, and this can happen very early in life. Just imagine a young woman with uterine fibroid that need embolization. It can be easily done and safely done through a radial access. And this person has a problem solved, but still all her life ahead, and she may be in need of future radial access. The point of the radial artery occlusion is this complex problem. There are different phenomena facing. You have to preserve flow, and the enemy of flow is thrombus. The sheath size may be used. If you use a small sheath size, it may promote flow during the procedure, so reducing the risk of thrombosis. The same for anticoagulation, but they are also a variable playing against your maintenance flow if you have an arterial wall injury or spasm or the hemostatic compression. And 2 years ago, an international consensus on best practice for reducing radial has summarized the many. There is a bunch of practice of technique that you can implement just to preventing a radial artery occlusion. And there are a lot. And if you think just two factors, the extreme variability of the access size that we can implement for our procedure and the large variability of antithrombotic regimen, you can go from minimal dose heparin for a pure diagnostic angiography to a 4-drug regimen in a primary PCI. And so if you yearn for the lowest possible incidence of radial artery occlusion, the combination of just these two factors may require a truly individualized approach for hemostasis. And this is quite impractical on a systematic basis. So is there something better than that? Probably yes, and I would suggest it's this radial artery access. And it has been first described in 2011 by Aftendi Babunashvili. They used it for opening just for opening radial artery occlusions. And a few years later in Russia, Alexander Kelding, by observing spontaneous pulse of his distal radial artery, was inspired and switched all his practice to distal radial axis. And it's probably the first demonstration of the possibility to switch one's whole practice. In 2016, in Iran, Dr. Farshad Rogani Dekordi presented data on distal radial axis just to overcome a problem he was facing, namely women presenting with retrograde bracelets that it couldn't remove and that were covering the forearm. And then after, Ferdinand Khamenei promoted the left snuff box approach just to have a better ergonomy of the procedure for both the patient and the physician. And after that, Twitter spread the word. So there are basically 2 points of puncture for this radial axis. The first one is in the anatomical snuff box that is limited by the extensor pollicis brevis and abductor pollicis longus tendons proximally, and the extensor pollicis longus tendon distally, and the floor is made of the scaphoid and the trapezium bones. And the second point of this radial axis is what we call the dorsum of the hand of the first intermetacarpal space, that is downstream the extensor pollicis longus tendon, and the floor of that is the first dorsal interosseous muscle. So the main rationale is that those points of punctures, those sites of puncture, are downstream the radial branch of the superficial palmar arch, and also downstream the carpal anastomotic network. That means, if you see here, it's a palmar view, and the dotted line represents the distal radial artery, and you see it's downstream the anastomotic network of the hand. So even if someone bad, namely an occlusion, occurs at that point, flow would persist in the forearm radial artery, and until you have flow, you won't have any thrombosis and you won't have any occlusion. And this is nicely demonstrated here. You have an incomplete palmar arch, but you see that the flow is turning around, contrast is turning around. The occlusion of this radial artery is simulated by a radial compression device that is maximally inflated. And I think this is quite inspirational. On this ground, we developed this pathophysiology study. So we enrolled healthy volunteers, 100 healthy volunteers, and we simulated radial artery occlusion by inflating maximally an hemostasis device in 2 different sites at the wrist level, so at the site of the conventional radial artery puncture, and at the anatomical snuff box. And we measure flow downstream in the artery of the thumb, and upstream in the forearm radial artery. So here the color code are green for the flow measured upstream in the forearm radial artery, and blue for the flow measured in the radiodorsal digital artery of the thumb. And so these are the results. On the left, you see what is happening to the flow measured in the forearm radial artery compared to baseline, that is the green bar. The simulated occlusion of the wrist determines very significant and marked reduction of flow. We here assess the peak systolic velocity that is not observed when the occlusion is simulated at the snuff box level. And so we mean this was quite obvious, but it's nice to show. And regarding the safety, so the flow downstream, we see that when we simulated occlusion at the wrist, there is a marked reduction anyway at the level of the artery of the thumb, the radiodorsal digital artery of the thumb, and this reduction is less significant. It's almost inapparent when the occlusion is simulated at level of the anatomical snuff box. But there are additional advantages of using distal radial access. The course of the artery is superficial to the fascial compartment of the hand, and so there is no risk of compartment syndrome. And the kinetic energy on the flowing blood is also lower, and it may favor a more practical ergonomy, especially for left side access, and also short hemostasis. The video you have shown is an extreme example. It was a pure diagnostic procedure where hemostasis was obtained just by hand compression in 3 minutes. There have been between 2017 and 2020 exactly 20 papers published in English language that assess the feasibility of distal radial access for coronary procedures. And in those studies, the success ranges from 70% to 100%. This is a graphical representation. The size of the dots represent the population of the patient enrolled in the study, and the turquoise band is the confidence band. We know because it's reported in some papers that authors have enrolled very first punctures, and despite this dispersion of success of the puncture, the blue dots represent those studies for which we have information on the rate of radial artery occlusion, and the overall radial artery occlusion rate is 0.075%. This is very, very low. And if you recall the meta-regression graph I showed in the very first slide, the rate were moving from 8% to 5% in dedicated studies. So it's impressive, and it's very hypothesis generating. There have been randomized clinical trial. The most highlighted one was the DAPRAO trial that has been published earlier this year, and it's from Mexico. It's a one-center RCT. And you see how this radial access reduced the rate of radial artery occlusion. It's very effective. And indeed, in that study, the number needed to treat is 13. So it's very, very low. Of course, the rates of radial artery occlusion are probably a little bit too much in the comparator arm, namely conventional transradial access. And if we compare on background of over randomized clinical trials that came mainly from China and India, the PRO trial is not preponderant. So there is a need for a more convincing randomized clinical trial, and it's on its way. It will be the distal radial trial. It is actually ending its enrollment of 1,300 real-world patient randomized to conventional transradial access or distal radial access, and the primary endpoint would be ultrasound assessed forearm radial artery occlusion between 8 and 48 hours. The main characteristics of this trial are the presence of very expert operators, the use of a thin wall introducer sheath, spasmolytic cocktails systematically used, adequate procedural anticoagulation, and the protocol implementing minimal pressure inflation or patent hemostasis, just to favor as much as possible the reduction and to implement a modern approach to radial artery occlusion management and avoidance in the comparator arm. And the results are expected late this autumn. There are reports of the use of this radial access for almost every kind of coronary procedures, from chronic total occlusion PCI to calcium debulking, primary PCI, but also percutaneous carotid intervention, and even there are reports of percutaneous balloon aortic valvuloplasty. So everything, we may say that everything that is currently done in our cath lab through transradial, conventional transradial access can be performed through distal radial access. This year we published a review on distal radial access, and we detailedly reported every step, and we commented on that, of the technique. I would just here summarize the most important step. The setup of the patient for a right distal access is essentially the same as for a right conventional access. For left side access, the operator may prefer a puncture on the left side of the patient, and then turning the arm to a comfortable position with the hand facing down on the right ground. And so it's basically like a right femoral access. But also there's the possibility of directly puncturing the left distal radial artery in a fixed position, and using an elastic net band is probably nice, just to keep the arm in a fixed position. The hand setup, it's important for the patient to grip something in his or her hand. It may be the thumb, or a roll gauze or syringe, or if it's available for you, the handle of a radial board system. And it's nice to recall that the thumb adduction promotes a shift of the radial artery in the anatomical snuff box, and on the other hand, the thumb abduction promotes the shift of the radial artery in the dorsum of the hand. So based on the site of the puncture, you can use these two maneuvers just to favor the switch of the radial artery. This is a video of the puncture after disinfection. You perform anesthesia with lidocaine, and then after just couple of cc is enough, and then you can puncture. This is puncture done with okay. The first symptom was not immediately effective. Then you can redirect the needle, and thereafter it's quite the same as every kind of access. And the main point is that the distal radial artery has a curvilinear course, and it's three-dimensional. So it's quite difficult to exactly predict the position of the distal radial artery. So you may accept, even if you are an expert, you're becoming an expert distal transradial operator, you may fail in puncture. And this is something not related to you, but it's related to the anatomy, and it should be accepted. I guess it's probably the main limitation of distal radial access. And also you have to consider that because of this binding of the vessel, the needle entry angle to the skin is not the same as the needle entry angle to the artery, and this is something that may probably guide the choice of an open needle technique. And I guess certainly in the first stage of the learning curve, this is rewarding. You may implement ultrasound guidance in a study from Japan. The ultrasound guidance improve the success rate of distal radial access. The difference over a tactile guided approach is quite limited, and on the right you see the technique. And it's nice to develop skills in ultrasound guided vascular puncture. If you have this opportunity, you probably would benefit of a high frequency probe for the distal radial access. But not all the cath labs have two types of vascular probes, so you really need to develop your skills, and it's worth learning that just to be able to implement this backup when you need. The hemostasis can be performed in almost every fashion. You see here from left to right, from the most simple to the more complex, and it's the dedicated device, and there are no report of difference in the outcomes according to the type of hemostasis. If you are using the TR band, you need to remove the hard plate or artery plate that is inside, just to have a better conformability of the band around the hand. And this is a demonstration of hemostasis. This is the hemostatic device that is available in my cath lab. It's an alternative to the TR band, provided without the hard plastic plate. And this is quite a typical. You inflate and then you remove the introducer sheath. And it's very nice to implement the minimal inflation protocol that is akin to the patent hemostasis protocol. And since it's the distal artery is puncture and the kinetic energy of blood is lower, you can deflate a lot until you see a spot of blood, and then you add 1 cc of air, and so you are almost sure that the artery is patent at that point. There have been some concerns. Some people have expressed some concerns regarding possible complication linked to the erosion of the small bones of the hand. But indeed, to date, there are 2 published cases reporting complications of distal radial access, and there is 1 hand hematoma and 1 pseudoaneurysm. And because, as I've told you earlier, the course of the distal radial artery is outside the superficial to the fascial compartments of the hand, and the hematoma may be very terrific. And we had a case also. It was a young lady. She was working. She was a secretary, so she was typing the keyboard all the day, and she had one had like a baseball glove, and so we were a little bit concerned about that. But it resolved without any sequelae, and the lady is continue happily her job. So this is important to know. The hand hematoma can be quite impressive to see, but it's without any clinical consequence. Well, to implement a transition to distal radial access, I guess it's important to have some idea and some knowledge, some experience with conventional transradial access, because otherwise you will have to learn 2 things at the same time. So it's important also to acquire some proficiency with ultrasound guided puncture. It's very important to acquire a good knowledge of the anatomy of the radial artery in the hand, and especially to understand the three-dimensional course of the distal radial artery. And the fact that this three-dimensional course is not always the same, there are variability, and if you implement systematically ultrasound guide puncture, this will help you to understand that. But anyway, it's just important to be easy with that. The course is variable. You always feel the pulse. You feel the pulse in the same spot, but indeed the artery has a different three-dimensional course, and this may be potentially frustrating if you don't accept this limitation. It's quite important to interact with experts of this radial access, because you can exchange opinion, views, and acquire tips, tricks, and just it's nice to receive a piece of advice, and maybe this can promote a better development of your practice. There are two sites to point of distal radial access in the anatomical snuff box and in the dorsum of the hand. It's important to focus on one spot at a time, just to fully develop the competence. And if there is a need for starting, or so will to start distal radial access program, it's important to begin with a diagnostic simple procedure, and then the learning curve has to be completed not only by the operators but also by the learning staff as well. This will help, and indeed the higher simplicity, the better outcomes that you have with this kind of access really will be rewarding, and little by little all the staff, everyone will have a higher appreciation of that. And it's also worth to gain some knowledge and practice with slender technique. So using the smallest equipment that is justified by the procedure that is going to be faced. This is also a nice tip. So to conclude, we understand that conventional transradial access is associated with a lower complication compared to transfemoral access, especially in a high-risk patient. But radial artery occlusion may complicate transradial access, and when it occurs, patient may be denied the benefit of transradial access in case of repeated procedures. And indeed, there are some people that are that may undergo several procedures. They become frequent flyers, and we know this is not occurring at higher rates than in the past. So in an evolving interventional world, distal radial access is emerging as an important practice to reduce radial artery occlusion. And just to make the point, distal radial access is an operator prerogative that is implemented before the procedure starts. So you can choose to do something that will almost certainly benefit the patient, and it's in your hands. And distal radial artery access promotes quite effortless and certainly safe hemostasis. That is in contrast to the fragmentic management that is provided after the procedure. Indeed, if you can ensure distal radial artery access, you are almost sure that the patient will have a patent radial artery after the procedure. So you don't have to pay attention to anything else. The different type of hemostasis techniques haven't shown any difference in the vascular outcome. In contrast, when performing conventional transradial access, you need to implement several techniques, and it goes further the presence of the patient cath lab. The nurse staff has to deflate progressively the compression device, and that is this is outside your control. It's imperfect, and indeed it leads to a residual rate of a radial artery occlusion. So my final word is this: give it a try, but not give it a try once just to understand it, but try for every radial patient. It only costs you 1 minute. You may attempt. If you fail, it doesn't matter. Everyone is failing, even expert distal radial access operator. It's not related to you. It's related on the anatomy, and it's quite easy just to turn the hand. No, you may disinfect the wrist and the hand, and after attempting here, it's quite easy to turn the hand and go with the conventional radial access if the distal radial access has failed. I really encourage you to do it this way. I thank you also for your attention.
Gregory, grazie mille.
Grazie, Azim.
That was really an awesome presentation, and you know, I've been dying to have someone talk to us about distal radial. I started doing it a few years ago when I was in Italy, and then when I came to the US, I tried to get it going again, and I guess I gave up myself. But you've inspired me again. So actually, the last few weeks, I have to tell you, I've started again going completely to distal radial. But now we're going to also start using it for all our TAVRs. You know, all our TAVRs, we do our secondary access from radial, but we're going to do distal radial now, I think, for the TAVRs too. It just, you know, I think the incidence of radial artery occlusion is not insignificant. And, you know, the Mexican study says 8%. I think in real world practice, it's probably even higher at times, because I'm not sure that everyone does patent hemostasis as well as it should be. All right. So I wouldn't be surprised if it's a little bit higher, actually. I've been really happy, I must admit, with the cases I've done with distal radial. I've been able to do, you know, left mains, rotablator, just about everything I can in a more relaxed fashion. So I think today you've convinced me again, so I'm going to push even harder to do more. But we have some of the fellows on, so I'm going to ask the fellows to maybe ask some questions and share their comments, and then I have a couple of questions for you as well at the end, Gregory.
Okay.
Hi, Dr. Sgueglia. I'm
Hello.
Andrea Scotti. Hello. Thank you for this lecture. Yes. I wanted to ask you just a question. The risk-benefit ratio for diagnostic procedure is, of course, in favor of this technique. I was wondering, in your experience, have you ever had to change your access to a more proximal one when you find out a lesion and you have to do a PCI requiring a larger sheath, or you performed all the procedure with, finished all the procedure with the distal access?
No, it never happened. Sometimes we very few times, to be honest, we need to upgrade the size of the whole system, but we did it through the distal radial access. You okay. Really there is the report of the aortic balloon valvuloplasty. So you know, the artery is more elastic than you can expect by measuring the diameter by ultrasound. Probably the limitation of the size is linked to the success of the puncture. A smaller artery is more difficult to be punctured at the first time. This is, in my opinion, the true limitation of the access size.
Okay, so do you evaluate it with tactile pressure or ultrasounds?
I do it by tactile pressure, unless it doesn't work, and then I use the ultrasound guide as a backup. But for that, honestly, I started learning ultrasound guide procedure for conventional transradial punctures. I was trained transradial, so it came almost natural for me. I would say it's normal for every interventional cardiologist that has been trained transradial, it's the same way. But I just to develop the understanding of how to deal with the probe and the
needle.
And the needle. Thank you. I went for gaining this the skill in a comfortable zone that was conventional transradial access. And then after that, I implemented for distal transradial access. And it's a bit different because you are the tendons that are disturbing you a bit. But after you learn a couple of tricks, it is quite smooth. It's very nice. And it helps you understand the anatomy also of the radial artery. And
I just wanted to make a comment about Andrea's question, Greg. So people who are resistant to radial always talk about, the main reason is because they need large bore sheaths, so they need 7 or 8 French guides, or because of lack of support, right? And I'm the first to say, having trained, with Antonio, first femoral, and then I completely switched to radial about 10 years ago. Having a long sheath from the femoral, a destination sheath with a 7 French guide gives you incredible support. But when you switch to radial, and you make that idea to switch to radial, you then learn how to overcome the limitations of maybe slightly decreased support. So you learn to choose your guide catheters better and make sure you have the right guide catheter for that case. You learn to use support wires to give you more stability. And now we also have things like guideliners, right? So, I must admit, for me, I can't remember the last time where I did a case where I said, I started the case via radial. And I said, no, I'm going to switch to femoral because I need more support. Mm-hmm. It's very rare. But it happens early on in your learning curve. But once you actually gotten over that point where you accept that there are other things you can do to increase support, right? You can use, anchoring balloons, you can use guideliners, you can actually do everything. You can do, even if I'm doing a left main with 2 stents, so I'm doing a 1.75 burr, I do it with a 6 French guide. And there's not been issues with doing that. So I think it's kind of a little bit of a mind state change that you have to change your state of mind about what can be done, what cannot be done via the radial.
I agree with that. It's a different animal. The transradial approach is not the same. You cannot transfer everything, all your practice from transfemoral to what is occurring inside the coronary artery is the same, but just for joining the coronary artery, it's a little bit different. And there are devices have been developed. There are the fin wallet introduced, so you can so spare some thickness of the introducer sheath. You can use a larger guide catheter despite a smaller introducer sheath. So you may use those tools. It may be even funny if you want. It's more interesting. And for support, just having a low threshold for using a support guide wire, it's very nice. When you understand, you foresee that maybe you will have some issue, just put inside a second guide wire and you will save the game. I guess you will lose 10 seconds for that, and it's a nice investment, but because otherwise you lose a lot of more time. And yes, it's a different state of mind. You say it very well.
I like the distal radial because I'm a left radialist, I call myself, because I switched from right to left because I had some cases when I started of very bad tortuosity of the innominate, which made it very challenging. And there's enough data now showing that the left has less tortuosity, but it was a little bit more uncomfortable. And distal radial makes it just that much more comfortable. The other trick I don't know if you've been using them, Greg, that I've been doing, if I have very bad tortuosity of the left subclavian, I've been using R2P sheaths. So the radial to peripheral sheaths from Terumo, they now come with short ones, like a 75 centimeter one. And I've been using those for some of my very complex cases where I have marked tortuosity, because you can park the sheath in the arch of the aorta. And so you have a sheath from the radial all the way to the arch and then your guide catheter, and it gives you incredible support. So that's also quite useful to do.
Very nice. It's the equivalent of the long introducer sheath that is typically used from the floor.
Exactly. Yeah.
It's very clever use of the tools that are available.
Yeah. Nikos?
So thank you very much for the presentation. In one of your slides, you showed quite a bit of variability, like 70 to 100% the success rate. And some of these, of course, has to do with like operator experience and learning curves. Are there like some clinical characteristics of the patient that would make you more prone to fail? Like, in other words, are there some patients that you wouldn't even attempt to do a distal radial? I was reading some papers that female and people with like lower blood pressure, when you don't use ultrasound, can be like a setup for failure. But what is your experience?
Well, if you feel the pulse, it's easier. If you don't feel the pulse, the distal pulse, it's not so easy. You can be successful anyway, but it's the rate of success is lower. For starting, it's very important to select patient with a very good pulse. And if you noticed, I hope you did, in the historical slide, there was an image showing a spontaneous pulse. It was quite evident in the dorsum of the hand. This is the absolutely the best situation to start. And when you gain experience and confidence, you can slowly try to attempt, and you will fail anyway, but lesser and lesser with time. And after that, you can be ready to face almost all situations. It depends probably on your experience, I would say, but with conventional transradial access is the same. It's better to start puncturing a nice pulsating radial artery at the wrist rather than a very very small and poor pulse. It's less easier. It's the same concepts apply for this radial access. Women, small light frame women, or typically have typically more frequently a smaller artery. So yes, it's expected that starting with small women may be more difficult. So my suggestion is really to try very without keeping in mind that it is normal, that you won't be successful 100% of time. Nobody will be successful 100% of time. And but when you are successful, you very you may be satisfied by what you did, because you probably almost certainly avoided the radial artery occlusion for the patient, and certainly ensured him or her to have a pattern radial artery after the procedure.
Thank you.
It costs you 1 minute.
So Greg, what percentage, I'm assuming you're like me, that over 95% of your cases are radial. What percentage of your radial cases are distal versus normal radial?
Actually, they are half and half because of participation in this radial trial.
Okay.
Otherwise, I am not just when you have an interest on the topic, it's nice to explore in depth, and so I am trying to implement this radial access in every cases, and so. Would say that the failures are quite low, but they are failures. And if you are in a hurry, it's maybe more pragmatic to switch to conventional transradial access. Just imagine a STEMI patient, after a few attempts, it doesn't work, it doesn't matter. You go conventional transradial and you ensure that the procedure be done. This is the priority, of course. But just because it's really, I have the radial bore system with the handle, and it's really easy. The patient turn the handle, and it's switching from one position to the other in immediately.
Okay, excellent. Manav?
Thank you for a great talk. I've also been doing a little bit more distal left radial in the last few weeks, and I had a question. When using ultrasound, sort of a technical question, and you're scanning sort of from distal to proximal, there is a point in the distal radial artery where it takes sort of an acute bend before it straightens out and then joins the radial artery. I'm just wondering if you're using ultrasound, it looks like in the anatomic snuff boxes in the middle of that bend, are you puncturing it in the bend, or are you trying to go more distal or more proximal to that bend? Any comments on that? And it was sort of apparent in a lot of the drawings or the that you showed of the schematic of the distal radial, this kind of like 45-degree bend in the artery. So just trying to understand technically where you're puncturing.
Well, what my current understanding is that the snuff box is like a pentahedron, so a 3D volumes, and the radial artery connects one vertex to the opposite, and so puncturing proximally increases your chance of being successful. This is probably one take home. And because in this 3D volume, the artery may have different kind of bindings, and sometimes is quite unexpected direction, and it's almost transversal. You will find this radial arteries are almost transversal in the snuff box. But at the vertex, so very proximal, there is the path, because it's turning around the hand and it's going to the wrist, and so there is a high probability meet to meet the artery in that spot, and this is my advice to attempt puncturing proximally in the snuff box.
Yeah, great, thank you. And then I guess a follow-up question, which you sort of addressed, is that you don't really use the size of the vessel on ultrasound to rule out your ability to put in a 6 French sheath or something like that. You're saying that the artery, even though it sometimes appears very small when it branches off the common radial, will in your experience accommodate a 6 French slender almost always.
Yes, actually I'm using the 5 French slender, and there is a lot of procedure you can safely perform with a 5 French guide catheter. And if you need for an upgrade, just in those cases, you upgrade for the bigger slender sheath, and it's okay. You just compress the artery, and you won't have any blood loss, and this won't cause any trauma to the vessel. And there is even an advantage. You have already performed your diagnostic angiography, let's say, or you acquired the relevant image with a smaller equipment, and then after you just implement the bigger one for what you need. And this will not occur in all your cases. This will occur just in a minority of cases, and it's something, I guess, important you've done, because the size of the sheath is a determinant of this work as well for a conventional transradial practice. The size of the sheath is a determinant of radial artery occlusion. So it depends on what you are facing. If it's an STEMI patient, you need first to do diagnostic, and then after maybe there's a need for ad hoc PCI. It's the focal lesion of the right coronary artery, honestly, you don't need a 6 French gauge catheter for doing that.
Sure.
You can, no? And in most occasions, you cannot anticipate what you are going to face. If you know you have to treat a CTO, high JCTO score, probably you need to implement from the beginning a different strategy.
Thank you. And a quick follow-up: long sheath versus short hydrophilic sheaths. Any preference in the distal radial?
Honestly, I have experience with the Terumo one, so I cannot compare with the other brand.
Yeah, and Terumo makes a few different sizes. Do you use the shorter? I think it's like 11 centimeter sheath, and they also make a longer.
Oh, sorry, you asked me for sorry.
The length.
Well, I'm using the 11 centimeter, and I guess it's a good choice because it allows you to reach the forearm radial artery, but not too much. And so if you use a larger one, the trauma to the vessel wall will be limited to just a small portion. And but it's important to reach the forearm radial artery with the sheath. So using an excessively short sheath, I guess it's not a good idea because of the binding of the radial artery in its distal course.
Thank you.
Samina, Bob, any questions?
Yes, thank you so much for the talk, sir. Just to touch back on radial artery occlusions and, proximal versus distal radial access, the disco trial on the schematic you showed said something about minimal pressure technique. Sometimes that's a fine balance between pseudoaneurysms, hematomas in the proximal portion, but they stress that actually minimal pressure should be applied and then anticoagulation. In your experience, the incidence of radial artery occlusion, do you think is proportional to us over inflating the TR band or putting too much pressure? Because we are concerned for hematoma formation. Would you say we should just be shy of bleeding when we put on that band? That's my first question. And second question, do you think that this can be generalized to PCI procedure where the patient is fully anticoagulated to take out a distal radial sheath safely?
Well, safety first. This is obvious. You attempt to deflate. When you see a spot of blood, you reinflate and you assess. If you need to reinflate again, you do it because, of course, you need to avoid an hematoma, bleeding. This is important. And you don't have, there's not a linear relation between the amount of air in the inflation device and the rate of radial artery occlusion. It's a matter of probability. When the compression is high, your probability of having a radial artery occlusion is higher, the same as for time. When the time of compression is longer, the probability for having radial artery occlusion is longer. There's a nice study, it's called RAP and BEAT. I guess it had been published in Eurointervention, and it's a multi-center study just to assess the performance of the fin wall introduced to sheath. And what they found, it's a very marked difference between what is occurring in Japan and in other countries. In Japan, they had this kind of tradition of implementing 1 hour compression for every French of the introducer sheath. So if you have a 5 French introducer sheath, it's 5 hours of hemostasis compression. This is a tradition, and you know that in Japan, tradition is important. It doesn't mean that in every single hospital it works that way, but it is the most dominant practice of hemostasis. In Europe, it's different, and they found a very significant difference in the rate of radial artery occlusion between Japan with prolonged hemostasis time and Europe, where there is not such kind of performance. This is, I guess, the answer to your first question. And I'm sorry, I just forgotten the second one. Just recall me
The
briefly.
second question was just heparinized when someone.
I guess it's the same. It's the same. Anticoagulation doesn't. It just it's a matter of pressure. If the external pressure compensates the pressure that is inside the artery, you won't have any bleeding. It's dynamic because the patient is potentially moving his hand, his wrist. I encourage you. I've did it. I've put around my hand a compression device, and I've tried to remove it and attempt some Houdini. Some Houdini maneuver, and I couldn't do it. It was very safely assure around my hand, and so this encouraged me for using the compression device, the TR band, or its analog. So
Thank you.
Greg,
before I pass you to Samina, one of the challenges I've had here in the US, because Radial is still not being adopted widely in all the centers, is that often you put on either TR band, or we've been using for our distal radial the Merit band on the hand, and then an hour later there's swelling near the puncture site. Okay, and the automatic response has been to remove the TR band, okay, which is like almost the opposite, is exactly the opposite thing of what you should be doing, right? Because if there's swelling, there's bleeding, and you need to compress more. You need to make sure you're compressing at the right place and then increase your compression. So I actually, early on when I started doing distal radial, I had a patient with a huge hematoma, like the picture you showed. And all because the team, when they saw some swelling, they thought it was from venous congestion. Okay, and they removed the band. And so, it's one of the things I wanted to reiterate to the fellows is that if you see some swelling at the puncture site with either distal radial or normal radial, don't remove the band. Check if it's in the right place and maybe even increase the amount of pressure you put in.
Yeah, and this is the reason why the learning curve must be performed at the whole team.
Yeah,
it's just not about the puncture technique. It's just about everything. And this is a very nice example of how a very simple details may compromise the success of the procedure. Also, for the same reason, starting with simple diagnostic procedures with low heparin is better, because if something like that occurs, the consequence are less important. And sometimes when when learning, you have to refrain from your enthusiasm and just wait that everyone has gained has been accustomed to that.
Yeah. Samina?
Thank you so much for the great talk. I have one main question and another question later. What is the incidence in your experience? What's the incidence of peripheral nerve injury with the distal radial technique from the snuff box? Is there something that we should discuss with patients before, when we get the consent, basically the risk of peripheral nerve injury comes with this technique?
I didn't hear you well. Did you ask me about the sensitivity issue, nerve
yeah, the
damage?
nerve injury. Yes, correct.
Okay, that's fine. We have completed a study that has been inspired by Ferdinand Kimenei, and we assessed the hand function, the motor hand function, and the sensory hand function. It was done at baseline, 1 month after the procedure, at 6 months, and 12 months then after. And we didn't see any difference. We used a dynamometer. We used the Weinstein monofilament test, that is a test that is used for the sensory the sensory sensitivity of the skin, and we use also questionnaires, self self-filled questionnaire by patient, and we didn't find any difference with time. And there are a few patients that had a worsening of their results, but those worsenings, we test both sides, both hands. They were occurring on both sides, so probably it's not related. There are very few having that, and it's not related to the puncture, because it's occurring on the other side as well, and the entity of the change is identical. So we are quite confident about that. We didn't observe that in our experience. The case of the hematoma we had, I guess it's the same as the one that Dr. Latib has described. The consequences then after were absolutely nil. Our patient was a secretary. She was typing the keyboard all the day, and she continued. She needs truly a good coordination, somatosensory coordination, and it doesn't. The procedure doesn't compromise that. She continued working as prior. It's only one case, but it's the most alarming situation we experienced, and it provides this kind of very positive evolution. And otherwise, we didn't have any signal. Anyway, we performed the study, and the study demonstrated that it's going to be presented. And I hope at EuroPCR. So stay tuned. We have to wait.
Very nice.
All the time to be agree on that. Okay.
Thank you so much. And one last question. You know, I'm an interventional fellow, like 4 months into my training, relatively inexperienced with the distal radial. Thanks to Dr. Latib, we've done a few cases. But for someone like me, when you say try a few attempts, what is the few attempts that we should try? Like, is it 1, 2, 3? How many times should we try before we give up?
Well, I guess it's, I would say a couple of attempts is a nice compromise. Just, but if you feel the pulse, you're confident for that particular situation, you can give. It's the end of the day. You have some free time. It's the last case, or you're not in a hurry. And maybe you can at that point ask for the ultrasound probe and try the ultrasound guide procedure. But you know, it's a nice trick to have. It's a nice technique to develop, and I guess that it will be of increasing. It will develop in the future. So starting now during your training to acquire these tools is a significant add-on. It's something nice. I really encourage you, and you have some times to do that, yeah, and take this opportunity.
Excellent. Greg, thank you so much. It was really a great presentation, but also the discussion, I think, was really fantastic. It was great teaching for all of us, especially the fellows. And like I said, you've inspired us to do more distal radial. There's no reason why we shouldn't.
Thank you, Azim. Thank you, Juan. It was really a pleasure to join you.
Thank you for taking the time. We look forward to seeing you in person. Okay. Grazie mille. Stia bene. Okay. Ciao, ciao.